Hi, I'm Bill.
I'm Rebecca.
I'm Tam.
And I'm Maddie, and today we aim to educate our fellow sonographers about pelvic inflammatory disease. This slide lists the topics we will discuss throughout our presentation.
Pelvic inflammatory disease is a diffuse infection-induced inflammation of the female upper genital tract caused by canalicular spread of bacteria. PID predominantly manifests in 15 to 29-year-old women. This condition encompasses any inflammation of the endometrium, fallopian tubes, ovaries, broad ligament, and/or pelvic peritoneum. Risk factors for PID are similar to those for sexually transmitted infections and include young age, multiple sexual partners, and lack of contraceptive use. Bacteria can also be introduced through invasive gynecological procedures. Cyclic changes in hormone levels and cervical mucus viscosity often influence bacterial ascension. The extent of inflammation determines whether a case is classified as acute or chronic. Acute PID, which is less than 30 days of duration, involves inflammation of the endometrium. Bacteria can also spread further into the fallopian tubes, often by retrograde menstruation, and still be classed as acute. Chronic disease involves long-term inflammation or recurrence of previous inflammation and is characterized by spread of bacteria to the ovaries, broad ligament, and/or pelvic peritoneum. Late in the progression of PID, a tubo-ovarian abscess can develop, which complicates the treatment process. If diagnosis is delayed or PID is left untreated, the fallopian tubes can become scarred and obstructed. This increases the risk of ectopic pregnancy and infertility, as egg transport can be impaired. Adhesions within the pelvis can also result from lack of treatment and cause chronic pelvic pain. Ultrasound is routinely used in the assessment of PID to identify specific signs, determine the complexity, and rule out other diseases.
Pelvic inflammatory disease is caused by both natural vaginal bacteria and sexually transmitted bacteria. However, sexual transmission is the most common mode of acquisition. These organisms cause microenvironment changes, resulting firstly in vaginitis and cervicitis, before provoking further inflammation of the upper genital tract as they ascend. The red areas in Figure 1 show the portions affected by PID. Ultrasound is the preferred method of diagnosis for pelvic inflammatory disease, as it is easily accessible and does not utilize ionizing radiation. Furthermore, the Doppler capabilities of ultrasound allow real-time demonstration of blood flow characteristics such as hyperemia of the fallopian tube walls. A transvaginal approach is favored over a transabdominal approach because it provides more detailed visualization of the structures involved. Additionally, transvaginal scanning does not require a full urinary bladder, making it more tolerable than transabdominal scanning for patients with acute pain. A curvilinear array or sector probe in the 2 to 7 MHz frequency range is used for the transabdominal scan. To begin, the transducer is placed longitudinally in the midline superior to the pubis. The transducer is then healed to visualize the fundus of the uterus using the bladder as an acoustic window. The uterus, vagina, and cervix are assessed before using zoom to assess the endometrial thickness. The probe is then rotated into transverse and angled cranially and left laterally, whilst to the right of the midline to visualize the left ovary. This is repeated on the contralateral side for the right ovary. Figure 2 and 3 demonstrate the probe positioning and resulting image for a transabdominal longitudinal scan. Figure 4 and 5 demonstrate the probe positioning and resulting image for a transabdominal transverse scan. For a transvaginal scan, a transvaginal probe in the frequency range of 4 to 7 MHz is selected. A probe cover is applied and the probe lubricated with gel prior to insertion. It may be more comfortable for the patient to guide the insertion of the probe. The probe is slowly rotated anti-clockwise to turn from sagittal to transverse and slightly angled towards the fornix to visualize the adnexate while preventing patient discomfort. Figure 6 and 7 demonstrate the probe positioning and resultant image for a transvaginal scan of an anteverted uterus. Figure 8 and 9 demonstrates the probe positioning and resultant image for a transvaginal scan of a retroverted uterus.
Patients with pelvic inflammatory disease are predominantly young women of reproductive age. Most cases are asymptomatic, however patients may present with lower abdominal pain, pelvic pain, and diffuse bilateral adnexal tenderness, usually amplified with sexual activity. Secondary symptoms such as oral temperature over 38.3 degrees, mucopurulent cervical discharge, and urinary frequency can also aid in diagnosis. Physical examination may reveal cervical motion tenderness. uterine, adnexal, and abdominal tenderness, and adnexal masses. Laboratory findings associated with PID include elevated white blood count in blood or vaginal secretions, high erythrocyte sedimentation, elevated C-reactive protein, positive gonorrhea and/or chlamydia, and positive bacterial vaginosis. The vague nature of presenting symptoms in patients with PID causes a high rate of misdiagnosis. The long-term consequences of this disease can be significant, so correct diagnosis is imperative. As well as the increasing risk of ectopic pregnancy, infertility, and chronic pelvic pain, infection can also spread to adjacent organs, such as the bowel, and result in scarring. A diagnosis of PID is now recommended for female patients that present with pelvic or lower abdominal pain, cervical motion tenderness, and uterine adnexal tenderness. Sonographic findings for this disease differ depending on the stage of its progression. Sonographic findings, though often non-specific, include a mildly enlarged uterus with indistinct margins, blurring of the myometrial-endometrial junction, thickened and heterogeneous endometrium, and fluid within the uterine cavity. Indistinct borders of pelvic structures and fluid in the posterior cul-de-sac are also consistent with PID. The inflammatory nature of PID causes the fallopian tubes to thicken and dilate with echogenic fluid, and findings of incomplete septa, infolding, projections into the lumen, and hyperemia of the walls are not uncommon. Advanced findings of PID include ovarian enlargement and adherence to adnexal structures, contributing to ill-defined tissue planes. The development of tubo-ovarian abscess is often a bilateral process, however it may also be unilateral. TOAs appear as a complex adnexal mass with indistinct thick walls, internal septations, and/or complex internal echoes. They are usually well perfused and demonstrate low resistive pulsatility indices. Bilateral TOAs may completely fill the uterus, obscuring the uterine borders. Hydrosalpinx, which is fluid accumulation within a scarred obstructed fallopian tube, is a characteristic of chronic PID. Sonographically, it appears as a sausage-shaped or ovoid with thin, distinct walls and incomplete septa. In cross-section, hydrosalpinx exhibits beads on a string sign, which shows 2 mm echogenic nodules lining the walls of the tube.
One key sign of pelvic inflammatory disease is fluid within the uterine cavity. This is demonstrated in Figure 10 as a hypoechoic strip in the body and distension of the fundus of the uterus. Figure 11 shows a normal uterine cavity not distended with fluid. Figure 12 demonstrates an enlarged ovary with numerous tiny cysts and a thickened fallopian tube in the transverse plane. These findings are consistent with pelvic inflammatory disease. These images show an abnormally dilated fallopian tube displaying the Coleridge sign. The mucosal folds seen within the lumen outline the teeth of the cork. Due to the polymicrobial nature of pelvic inflammatory disease, its treatment must specifically address the key pathogens, most commonly gonorrhea and chlamydia. An antibacterial therapy course, usually lasting 14 days, is started soon after clinical diagnosis. Even if there is a negative test result for aforementioned common pathogens, improvement should be seen within the first 72 hours of antibacterial convalescence. Hospitalization should be considered for cases where appendicitis cannot be excluded or TOA is suspected, where the patient is pregnant or severely ill, or where the oral antibiotics are contraindicated. Prevention aims at reducing the recurrence by testing and treating all sexual partners the affected patient had in the 6-month period prior to the onset of PID symptoms. Furthermore, education about safe sex practice such as condom use target the spread of pathogens that may lead to pelvic inflammatory disease.
Some symptoms of pelvic inflammatory disease are very similar to those of other conditions, and it is important that these conditions are considered in the diagnostic process. Differential diagnoses for PID include ectopic pregnancy, ovarian cyst complications, pelvic endometriosis, acute appendicitis, mesenteric lymphadenitis, regional ileitis, enteritis, inflammatory bowel disease, urinary tract infection, and renal or uterine colic. To conclude, pelvic inflammatory disease is an infection of the uterus, fallopian tubes, and adjacent pelvic structures, and primarily affects women of reproductive age. Due to the vague nature of presenting symptoms in patients with PID, there is a high rate of misdiagnosis. PID can have significant long-term consequences, and for this reason, it is imperative for sonographers to aid in the correct diagnosis of this disease. Thanks for listening.